cardiovascular system functions as assist and transport numerous substances throughout the body. That's the function of the cardiovascular system, to move things around. It transports nutrients, oxygen and CO2, enzymes and hormones, ions, transports metabolic waste to your kidneys, and transports leukocytes to aid in fighting infectious agents. So if you have an infection, it transports leukocyte things to that area. Okay. It also has a stabilization in body temperature. You're able to sweat, you're able to get blood vessels close to the surface to relieve heat. It has the prevention of loss of body fluids through the clotting process. So if you damage in the skin, get a cut, it clots, keeps your body fluids in place. It causes stabilization of pH and electrolyte balance. Okay. Blood has two components. Okay. It has plasma and it has formed elements. Okay. Plasma is the liquid portion of the blood. Formed elements are everything else. You know, the blood cells, cell fragments, and those are suspended in the plasma. They include your erythrocytes, which are your red blood cells. They transport oxygen and CO2. They include your leukocytes, which are your white blood cells. They function in your immune system, maintain your body's health. And it involves platelets. Platelets involved in clotting of the blood. Okay, so the two components of blood, plasma and formed elements. The formed elements are your red blood cells, your white blood cells, and your platelets. So here's your sample of whole blood. Let me see if I get my clicker to work here. There we go. Yeah, everybody see a little red dot? Kind of hard to see.
Yeah, it's super small.
Yeah, everybody can see this one, right? everybody see the white circle?
Yeah.
All right, cool. At least this part's working on the computer. All right, so here's your whole blood, which is everything. It's broken into plasma. Plasma is roughly 50%. If I can get it to go back to the right place. There we go. Plasma is roughly 50%, 46 to 63% of your plasma, okay, is plasma. Okay, consists of your plasma composition is your plasma proteins, your solutes, and water. Okay, plasma is mostly water, 92%. Other solids are 1%, plasma proteins are 7%. Okay. Your plasma proteins are albumins, globulins, fibrinogen, and regulatory proteins. Okay. Your other solutes are electrolytes, sodium, potassium, phosphate, magnesium, chlorine, etc. And your organic nutrients, okay, used for ATP production, and then organic wastes. Okay. So that's what plasma consists of. It makes up between 46 and 63% of plasma. And the plasma is composed of plasma proteins, other solutes, and water being 92% of plasma. Okay. The whole blood consists of your plasma and your formed elements. Your plasma, erythrocytes, leukocytes, and platelets. Whole blood can be fractioned, and you can form just plasma. You can centrifuge it to get just the plasma. You can get just a packed cells or just a platelets, depending on what you need. And the Red Cross fractionates the blood and stores it as either plasma or packed cells or whole blood, depending how they want to store the blood for what purposes they need it for. So again, plasma is just the liquid portion. Packed cells are just the blood cells, the red blood cells, the white blood cells. Okay, and platelets are your clotting factor. Okay, if you're treating a hemophiliac patient, okay, you don't need to give them a transfusion of plasma and packed cells. You need the platelets. Okay, so you give them a transfusion of platelets because they lack platelets. That's a blood clotting material. Okay, so depending on what the patient has, what the patient's needs are, depending on what blood is being used, how it's fractioned. Okay, so when you have packed cells, it's mostly your red blood cells. Okay, it has no plasma with it. That's going to make a big difference in some of our transfusions we'll be doing. whether they're safe or unsafe transfusions. Right? So whole blood, again, whole blood is your plasma and your protein, your fixed elements, red blood cells, white blood cells, and platelets. So whole blood, males usually have between 4 to 6 liters of whole blood in the body at one time. Females have 4 to 5 liters. Hypovolemic means low blood volume. Hypo means low, volemic is volume. So low blood volume, a patient is hypovolemic. Normal blood volumes is normal volemic. And hypervolemic is excessive blood volume. The pH of blood usually runs between, well, always between 7.35 and 7.45. Outside of that range, the enzymes cease to function, okay? And you will get extremely sick. Okay? So pH is always maintained between 7.35 and 7.45. Okay? Plasma. We talked about the plasma. That's the liquid portion. It makes up 55% roughly of the whole blood. Like we said, it consists of 92% water, 7% protein. Those proteins are your albumin, your globulins, your fibrinogen, and your regulatory proteins. And 1% the other solids, like your electrolytes, sodium, potassium, chlorine, sulfate, things like that. Organic nutrients and organic waste. And that's what makes it plasma. Okay, and that's the same slide we showed before. It shows that the whole blood and what the composition of plasma, what plasma is made of. Mostly water, 92% water. Difference between plasma and interstitial fluid. Okay, the interstitial fluid is the fluid that surrounds the blood vessels and surrounds the cells. Okay, so dissolved oxygen in the plasma, the concentration is higher than interstitial fluid. Remember, blood is delivering oxygen to your cells. So you bring it into your lungs, bring it to the heart, pumps the blood, that has a high concentration of oxygen. The interstitial fluid supplies the nutrients to the cells. The cells already absorb the oxygen. So there's a higher concentration of oxygen in plasma than there is in interstitial fluid. So oxygen diffuses into the tissues. Okay. Carbon dioxide concentration. The concentration is lower than an interstitial fluid. Okay. So in the plasma, the CO2 content is lower, so carbon dioxide flows from the interstitial fluid back into the bloodstream to get rid of the carbon dioxide, because the cells use up the oxygen and produce carbon dioxide and water. Right? So they produce carbon dioxide back into the interstitial fluid. So the CO2 level is higher in the interstitial fluid and lower in the blood vessel. So CO2 flows by diffusion from the interstitial fluid into the blood vessels. So it gets taken away from the cells. Right? I guarantee you'll see that on your exam. So plasma also consists of what's called dissolved proteins. Those are the proteins we talk about in the plasma. Interstitial fluid has no dissolved proteins. Okay, so you need to know the differences between interstitial fluid and plasma as far as oxygen content, CO2 content, and your dissolved protein content. Okay. So oxygen is higher in the bloodstream, lower in the interstitial fluid. CO2 is higher in the interstitial fluid, lower in the bloodstream. The bloodstream, the plasma consists of dissolved proteins. Interstitial fluid has no proteins. All right, so your plasma proteins. Plasma proteins we talked about are produced mainly by the liver. They make about 7% of the plasma. Remember, 92% is water. So 7% of these plasma proteins. There's 3 major classes of these plasma proteins. There's albumins, globulins, and fibrinogens. Albumins make up 60% of your plasma proteins. Globulins make up 35%, and fibrinogens make up roughly 4%. So albumins are the smallest of your plasma proteins. Okay? Those are the ones that contribute to your osmotic pressure. Remember we talked about osmotic pressure in this class? Yeah, we have. Those contribute to your osmotic pressure. Remember, semi-permeable membrane, only water can pass. Your plasma proteins cannot. So these plasma proteins determine your osmotic pressure in the interstitial fluid and in your bloodstream. Okay? They transport fatty acids and your steroid hormones. They get transported through your bloodstream by these albumins. There's 2 types of globulins in plasma. Okay? There's immunoglobulins, which are your antibodies that attack pathogens, anything foreign in the body. And there's transport globulins, which transport ions and hormones throughout the body. And the last group of plasma proteins is your fibrinogens. Those are the largest of your plasma proteins. And these are the ones that are involved in clotting the blood. Okay. So you got your albumins are your smallest, you got your globulins, which are your immunoglobulins, your transport globulins, and your fibrinogens, which are the largest of your plasma proteins. All right, there's our famous slide again, showing you plasma. Roughly 55% of the whole blood is plasma. And again, 92% that's water, 1% is small solutes, and 7% is your plasma proteins, the three we just talked about. Your formed elements. Formed elements are your red blood cells, your white blood cells, and your platelets. They make up roughly 45% of the whole blood. 55% was plasma, 45% is your formed elements. Of the formed elements, your platelets account for less than 0.1% of whole blood. Your leukocytes, which are your white blood cells, also account for less than 0.1% of your whole blood. Leukocytes include neutrophils, eosinophils, basophils, lymphocytes, and monocytes. We're going to talk about each one of those separately in a little bit here, and to what each one of those white blood cells do for response to an infection in the body. And then you have erythrocytes. Erythrocytes are your red blood cells. Yeah, they make up 99.9% of the whole blood. Okay, so most of your whole blood is red blood cells. Okay, 99.9%. That's your formed elements. Okay, so here's how the formed elements break down. Remember, formed elements make up about roughly 45% of whole blood. Okay, the platelets are less than 0.1%. The white blood cells are less than 0.1%. And the red blood cells are 99.9% of your formed elements. So most of the formed elements in blood is red blood cells almost exclusively. Okay. Okay, when you donate blood, when you go into the truck, the first thing they do before you're allowed to donate blood is to do a hematocrit to make sure you're healthy enough to donate blood and make sure you have enough blood volume to donate. It's also called a packed cell volume. Okay, it's the percentage of whole blood occupied by the formed elements. So it's how much red blood cells you have in your body. Okay, so males, the hematocrit has about 45% before they allow you to donate. And that's roughly 5.4 million red blood cells per microliter. So a microliter is 10 to the minus 6 liters for all our chemistry majors. Okay. So you take 1 liter bottle, like a liter of Pepsi, liter of RC Cola, whatever you guys drink. Okay. Divide that into 1 million parts. That one part of 1 million has 5.4 million red blood cells in it. Each one of those million parts. So there's a lot of red blood cells packed into that. So males have about 45%, females about 42%. Okay. So 1 microliter of blood consists of millions of red blood, like 5.4 million, we said. Males are 5.4 million, females are 4.8 million. Okay. The structure of red blood cell, okay, the shape, this allows it to function what it does. Allows it to be very efficient at carrying oxygen and carrying CO2 throughout the body. It's a biconcave disc, which means it's a disc, it's a circle, and it's concave on both sides. It comes in. Has a very thin central region, which measures about 7.7 microns in diameter. So a very small, thin central region. It lacks cell organelles. There's no cell organelles inside of it. It lacks a nucleus. Red blood cells have no nucleus, have no cell organelles, and they contain hemoglobin. Hemoglobin allows the bonding of iron and porphyrin rings, which allow you to bind oxygen and CO2. Okay, that's the shape of red blood cell. It's a biconcave disc with a very thin center portion. So this center right here is kind of dished out on both sides, and that allows it to pass through arteries and arterioles, very small blood vessels, through capillaries. Okay. Lifespan of red blood cells is roughly 120 days because it has no nucleus. It has no way of reproducing, has no way of maintaining itself. So it only lasts about 120 days, then it's recycled. Okay? So all circulating red blood cells, they lack a nucleus and they lack all organelles. So because of that, their lifespan is roughly 120 days before they get recycled. Okay, so it lacks a nucleus. Because it doesn't have a nucleus to make it thick in the center, allows the cell to be flexible. Okay, if the nucleus was there, the cell couldn't bend because it couldn't force its way around the nucleus. So it allows the cell to be flexible as it travels through the circulatory system, and it allows for more room for hemoglobin. You don't have the nucleus taking up all that space in the center. So you can bind more oxygen to the hemoglobin because it allows for more hemoglobin to be in there, higher oxygen content. Okay? They also lack mitochondria. Okay? Mitochondria produce ATP, produce energy for the cell to function, but it doesn't need that energy, right? Because it doesn't have the function. Mitochondria use oxygen to produce ATP. Remember the Krebs cycle and all that stuff from biology and other classes you've taken? We use oxygen to produce ATP. Okay? It would defeat the purpose for red blood cell, which is carrying oxygen to deliver it, to use it all up. So it makes no logical sense for red blood cells to have mitochondria in them because they're delivering oxygen. They don't want to use it all up. Okay? So there's no mitochondria in your red blood cells. Okay? So no nucleus, no mitochondria, no cell organelles, and they only function about 120 days before they have to be recycled and they break down because they have no way of producing energy for themselves. Okay, so as developing red blood cells lose nucleus and organelles, a mature red blood cell, erythrocyte, is basically a cell membrane surrounding water and protein. That's basically all it is. It's a biconcave disc, and it's just a cell membrane with water and protein inside of it. No organelles, no mitochondria, no nucleus. Inside the red blood cell, water is about 60%, 66%, about 2/3 of your red blood cell's volume. Okay, protein for the other 1/3 of the red blood cell. Okay, greater than 95% of that is hemoglobin. So 2/3 of red blood cell is water. The other 1/3 is mostly hemoglobin. Hemoglobin is responsible for transporting oxygen and carbon dioxide. Okay. Now, the binding site for oxygen and carbon dioxide is different. Oxygen binds to the iron in the porphyrin rings of the heme molecule. Carbon dioxide binds to one of the subunit chains. So it's not competing with each other. In other words, when the red blood cell binds oxygen, it doesn't take up the space for CO2 to bind. So it can bind oxygen and CO2 efficiently. They don't compete with each other. So it's able to bind oxygen, deliver it to the cells, bind CO2, and deliver it to the lungs to get rid of it. Okay? That's an important concept. CO2 and oxygen have different binding sites in the red blood cells. It allows for them both to be transmitted without competing or interfering with one another. Okay? There's roughly 280 million molecules of hemoglobin in every red blood cell. Okay, so there's a lot. Okay. Red blood cells. Red blood consists of 4 polypeptide subunits. Okay, there's 2 alpha chains and there's 2 beta chains. Each subunit contains a molecule of heme. Okay? Heme is a porphyrin ring. It's a ring structure that has multiple angles to it and then bonds into different silicon structures. I can't draw on the screen, but I'll show you a picture of a porphyrin ring in just a second. So each heme consists of an iron ion. So you have an iron ion surrounded by the porphyrin ring that's suspended, and that's where your oxygen binds. So iron binds to oxygen. So people that are anemic, can't get enough oxygen, can sometimes be iron deficient. Iron deficiency is a form of anemia because if you don't have the iron, you can't bind the oxygen to it. You can't form porphyrin rings, you can't form your structures. Okay. So the polypeptide unit binds the CO2, like we said. The iron binds your oxygen. The subunit, the polypeptide subunits, bind the carbon dioxide. Oxygen and carbon dioxide do not compete with each other for the binding sites, which makes it effective at transporting oxygen and CO2 at the same time. Okay, so there's what you look like. And these are your porphyrin rings right here. You can see all these little circular structures, all these little carbon, nitrogen, nitrogen, all these things. Those are your porphyrin rings. And these porphyrin rings get together and form those 4 subunits, and they support an iron atom inside of them. The iron atom is what binds the oxygen, and the CO2 binds to the porphyrin rings. Okay, you have 1 alpha chain, you have 2 alpha chains, alpha chain 1, alpha chain 2, and 2 beta chains, beta chain 1, beta chain 2. And in those alpha beta chains, they suspend heme units, okay, which is your iron suspended with porphyrin rings that bind your oxygen. And that's what hemoglobin is all about. All right, any questions on hemoglobin and how to affect the different subunits of it and how oxygen carbon dioxide bond? Everybody's got it? All right. Blood types. Everybody knows you have blood types A, B, O, and AB, right? This is how we determine those types. And it is important those types in a blood transfusion, that you have to match the correct donor with the correct recipient. If you don't, the red blood cells accumulate, they coagulate into a mass, and they lyse, they blow up. And it's not good for your patient. The patients don't do real well when you blow up the red blood cells. They have a hard time breathing. So blood types are determined by the antigens on the surface of the red blood cell. So every red blood cell, or most red blood cells have different antigens. Okay, you can have an antigen A on the surface. You can have antigen B on the surface. You can have both antigens, A and B, on the surface, or you can have blood type O, which has no antigens on the surface. These are called agglutinogens. The agglutinogens are either glycoproteins or glycolipids. Okay, so in the plasma blood, there are also proteins called antibodies. Those are agglutinogens. These respond to the different surface antigens. You know, if you have an antigen, it's a marker on the outside of your cell. If your antibody recognizes it, they tag that cell as foreign and tell your body to destroy it. So that's why if you have an antibody that's reactive to one of the blood you do a transfusion, it's going to mark it as foreign if it doesn't match. Okay, and that's what causes the problem. Okay, there's 3 main types of surface antigens, agglutinogens. There's A, B, and D. We'll talk about A and B and we'll put D off for a second. Antibody D is your Rh factor, Rh positive, Rh negative. Okay, so we got A and B are your blood types. Antigen D is your Rh. We'll get into that with different types of hemolytic anemia and stuff like that during pregnancies. So 2 major types of your surface antigens are antigen A and antigen B. People with type A blood, okay, have A surface antigen on their red blood cells, and they have antibody B in the plasma. Okay, so if you're blood type A, okay, I guarantee you'll see this on their final exam. I'm gonna give you different types of blood. You gotta tell me what they match. Okay, if you can donate it or not. Okay, so if you're type A, you have surface antigen A on your red blood cell, and you have antibody B circulating in your plasma, which means if there's a B surface antigen, your antibody is going to find it, it's going to bind to it, it's going to mark it, a little flag goes up, and your body's going to destroy it. It's going to find it as foreign. Is that making sense? Okay, if you're blood type B, it means you got B surface antigens on your red blood cells, and in the blood plasma, you have antibody A. So if anything with an A surface antigen shows up, that antibody is going to bind to it, marker goes up, and it's going to use phagocytes and destroy those red blood cells. It's going to clump them together and then lyse them and destroy the red blood cells. Okay, so whatever your surface antigen is, the opposite one has an antibody that's circulating in your plasma, looking for that oddball to find it, because it's going to mark it as foreign. Okay. People with type AB blood, okay, they have surface antigen A and surface antigen B on their red blood cells. Okay, and they've got no antibody circulating in their plasma because they have A and B markers. If they had antibodies in the plasma, they'd mark their own blood as foreign and destroy it. Okay, so people with AB blood have surface antigen A surface antigen B, and no antibodies circulating in the plasma. People with blood type O, okay, they have no surface antigens. They do not have antigen A or antigen B, those markers on their red blood cells. Okay? But they have both types of antibodies circulating their blood. They have antibody A and antibody B because they don't mark their own blood as foreign because they don't have those markers. So those are your 4 types of blood cells. Here's a good graphic of it. Again, blood type A, you can see surface antigen A, those little round circles. And you have antibody B. Those find B markers. See how those are circles? Those are looking for little triangles. Okay, so they don't bind to it. Here you have blood type B. Okay, blood type B has the triangle markers on the surface. That's surface antigen B. And they have antibody A. Those look for A antigens. Okay, blood type AB, you have both A and B markers, surface antigens on your red blood cell. And you have no antibodies circulating in your plasma. Blood type O, okay, you have no antigens, no surface antigens, no markers on your red blood cell. But in your body, in your plasma, you have circulating antibodies of A and B. So if a type O patient gets a blood transfusion that has an A or a B marker on it, it's going to destroy the blood. It's going to form a clot in your bloodstream, and the patient's not going to be happy when you gave that type of blood. That's why it's important to match blood types before transfusion. Okay, so different blood donations. Here's some examples. If you have a type B patient or a type A patient, you have packed cells. Now remember, packed cells mean what? Packed cells means you're not delivering the plasma. In the plasma is the antibodies. So if you have a type B packed cells, now a type B patient has surface antigen B on their red blood cell, and they have antibody A in their plasma. You don't have plasma in packed cells. Okay, so a type B packed cell donor cannot donate to your type A patient. Okay, you have type A patient, they have an antibody B. If you give them type B packed cells, these type B packed cells will have surface antigen marker B on it. So in the type A patient, they have antibody A. Okay, and they'll bind to. I'm sorry. I usually have to write on the make sure. Okay, a type A patient has antibody B in their plasma. If you give them a cell with a surface antigen B, it will find it as foreign. So it will not be a safe donation. It will agglutinate and then lyse. Okay. If you have type AB packed cells and you try to donate to a B patient, okay, you have a type B patient. Okay. Type B patients have what in their circulating plasma? Antibody what?
A.
Right, perfect. They have antibody A in their plasma. So if you give an AB cells, there's markers with A on it. They're going to find it. They're going to destroy it. They're going to mark it as foreign. So you cannot give a type B patient AB packed cells. Okay. Type B packed cells going to a type AB patient. Again, a type AB patient, okay, has what type of antibodies? If you're type AB, if your patient in the ER
None.
is type perfect, Sandra, they have none, right? They have no antibodies. So if you give them a B packed cells, they can take that because they're not going to find that as foreign. They're not going to mark that as foreign in the bloodstream. That's a safe donation. Okay, now you got to watch specifically when I do this on the exam whether you're donating whole blood or packed cells. If you're donating whole blood to a patient, you're giving them the red blood cells and the plasma from the patient. So now we got type B whole blood, which means we got B red blood cells, have B markers on it, and we're giving them anti-A antibodies, okay, because that's in the plasma. Okay, so if the patient is an A patient, you're giving them type B cells, what's going to happen? Okay, the B cell is going to be marked as foreign because the patient has antibody B in the body and the plasma. Okay, and also the B cells you're giving them are going to be marked as foreign. Okay, and also the plasma is going to have antibody A in it, and that's going to attack the patient's A cells, their surface antigens. So you're going to destroy the blood type that you're giving and the patient's blood type also. Okay? And that's not a safe donation. The patient won't survive that. Agglutination will occur when they mash together, and then lysis will occur. Okay, so be real careful when it says packed cells or whole blood. It does make a difference. Okay, AB whole blood cannot donate to a B patient. Again, a B patient just has what in their if you have a B patient with type B blood, what do you have in their plasma? What's circulating? What antibodies?
A.
Perfect, type A. If you give them AB blood, they're going to find the surface antigen A and they're going to destroy it. So that's not a safe donation. Type B whole blood cannot donate to a type AB patient. Okay, again, you have a patient that's AB. So what kind of antibodies are circulating in their plasma? What kind of antibodies does an AB patient have that's in your ER?
None.
None.
Perfect. It has none. Okay. Now you're giving them B whole blood. So you're giving them surface antigen B, which is fine because they don't have the antibody for it, but you're giving them whole blood, which means you're putting in antibody A. Okay, that comes with the whole blood. Type B patients have antibody A in their plasma. So now the antibody A is going to react with the surface antigen A of the AB patient, and it's going to cause agglutination. So that's not a safe donation. Okay. Type O packed cells can donate to a type B patient. Now, type O packed cells means you're not giving any plasma. You're not giving them any. Okay, so you're not giving them any antibodies, anything within the plasma. And you can donate to any type of patient because type O has no markers on the surface. So type O packed cells, you can donate to anybody. That's called a universal donor. Anyone can accept type O packed cells because there are no markers. There's no A or B markers to react to it. So I give it to an A patient, that's gonna be fine. I give it to a B patient. I give it to an AB patient, and I give it to a type O patient. So type O is a universal donor, but only if it says packed cells. Okay. If it doesn't take, if it has whole blood, then you can't do it. You have to match it specifically. Is that making sense? Hopefully that makes sense there. All right, type O whole blood, like we just talked about. You cannot donate to a B patient. Type O packed cells, you can. Type O whole blood, you cannot, because now with type O whole blood, with a type O patient, you have anti-A and anti-B antibodies in the plasma. So you have a type B patient, you're giving them, along with a type O blood, you're giving them anti-A and anti-B antibodies. The anti-B antibodies are going to find the B surface antigens and agglutinate it. So that is not a safe donation. Okay, so these are what's happening. These are the surface antigens. Okay, you'll either have A or B surface antigen or neither or both. If you have the opposing antibodies, they'll bind to it. These antibodies will bind to it. They'll stick together, forming a mass. This mass is called agglutination or clumping. And once they clump in this big group, it gets destroyed. Hemolysis. It lyses it. Okay, hemolysis, destroying the red blood cells. Okay, that's how it works when you destroy from the antibody reacting with the surface antigen. All right, here's a summary of what you just did. You have all your different blood types on the top. blood type A, whoops, go backwards. Yeah, blood type A, blood type B, blood type AB, and blood type O. And the important points are your surface antigens for A, surface antigens for B, surface antigens for AB is both, and surface antigen type blood is none. The antibodies in the plasma, you have anti-B in A, anti-A in B. You have no antibodies in the plasma for A and B, and you have both antibody A and antibody B in a type O patient in their plasma. And you can see the unsafe and safe donations. And when you get to packed cells, okay, packed cells make a difference. If they're packed cells, you are not delivering the plasma with it. So you're not transferring the antibodies from one patient to the other during the transfusion. You're just giving them the red blood cells. So like I said, an O packed cell, a type O patient with packed cells can safely donate. Oops, get my marker from back here again. Okay. Type O patient, packed cells can safely donate to every person. That's a universal donor. With packed cells, an AB patient can accept anybody's cells because an AB patient has no antibodies in their plasma. So if you're donating packed cells, an AB patient is a universal recipient. If you're donating packed cells, an O patient is a universal donor. So, but it's only for packed cells. Okay, you got to be careful between whole blood and packed cells because whole blood also transfers the plasma that has the antibodies in it. Okay, so when dealing for universal donors and acceptors, so for packed cells, the universal donor is O. For packed cells, the universal recipient is an AB patient. Remember, we said there are three types of glucose surface antigens. There's A, B, and there's D. D is your RH factor. RH factor is extremely complex. It's nothing as simple as A and B. All right, there's a lot that goes into RH factor, and we're learning more all the time with the RH factor. RH consists of 50 different blood group antigens. So instead of having A and B, that's just 1A, 1B, we got 50 of them that are antigen D. 50 different types of surface proteins. And there's getting more all the time. And we got more than our letters in the alphabet. So now we got D, we got big C, little c, we got big E, little e. Okay, those are the most important ones, those 5. Okay, but there's 50 different ones. Our RH factor has turned out to be an extremely complex antigen antibody reaction that occurs on the surface of red blood cells. The basic thing we need this for is during pregnancy. If the mother and the baby have a different RH factor, it can be a big problem. But it's only a problem from the second pregnancy on because they have to be exposed to it first during the first pregnancy. Okay, so you have RH plus and RH minus. That's what we deal with when we have a pregnant patient in your emergency room or in your operating, whatever you're in your office. Okay, so RH positive has the D antigen. RH negative does not have the D antigen. If the mother is RH negative and the baby is RH positive, that's when the problem occurs. You get what's called fetal hemolytic anemia. Okay, in the second RH plus infant. That can only occur the second one. The first pregnancy is no problem. Okay, when the baby's born, the mother's exposed to the blood. If the mother's exposed to RH positive, she starts to make antibodies to the RH to the RH positive, to the D antigen, because now she's exposed to it, and it's foreign. So her body starts to make antibodies to it. So now the next baby, if the next baby is RH positive, the mother's the mother's plasma is going to cross the placenta into the fetus and start to destroy the baby's blood because the baby's going to have foreign blood to her. Right? But only when she has made the antigen. If she's never exposed to that RH positive, she's never going to make that antibody. So only when she's exposed to it. So when the second child comes along, we get what's called RhoGAM. Use the curve, you give them RhoGAM, so it stops you from making those antibodies, and we're giving it like roughly the 28th week of pregnancy. And it needs to be given during the pregnancy after the first one, every symptom. You don't wait and see if the baby's RH positive, you just give the RhoGAM, week 28, and it goes right through, and the mother stops making the antibodies. Does that make sense? It's just one of the Rh factors. Again, it's a real complex situation, but we were about the D antigen. That's the one that the mother makes antibodies to that causes a fetal hemolytic anemia, which can be fatal to the infant, destroy enough of the blood.
Why do you wait till week 28?
That's when that's when it's most effective. You know, the mother doesn't start to develop it in response to it yet. The levels aren't high enough because it takes a certain level. At week 28, the baby starts to develop enough to where the mother starts to develop it. And at week 28, that's when we give it, and we want it to be effective because you want the dose to be effective at the right time. You don't want to give it too early and then have the mother respond afterwards. You don't get too late and the mother already responded. They figure that week 28 is right about when you want to give it for that response to have maximum value so that doesn't occur. Okay. But if you ever want to just do some reading on Rh, it's amazing with the different 50 antigens, what this does. It's nothing as simple as A and B. Okay. Oops, did I do that already? Here we go. All right, formed elements. We talked leukocytes. We talked about red blood cells. Those have your different markers on them. Now we're going to talk about leukocytes. Leukocytes are your white blood cells. They're used for your immune response. There's two main classes of leukocytes. There's a total of 5 major types. The 2 divisions of those 5 types are granulocytes and agranulocytes. Granulocytes mean it has granules in there. If you look at it under a light microscope, there's all kinds of granules inside that cell. The agranulocytes mean it does not have granules in it. Okay? So you got 2 classes, granulocytes and agranulocytes. The granulocytes, there's 3 types of leukocytes. There's neutrophils, eosinophils, and basophils. Okay? The agranulocytes, there's monocytes and there's lymphocytes. So there's a total of 5 types of leukocytes. 3 of them are granulocytes, 2 of them are agranulocytes. It just means the presence or absence of granules in the cell. Okay. Here's your summation right here. Here's your pictures of it. The granulocytes are on the left, and you look at each of those cells and see all these little dots inside the cell. Those are your granules. That's what they call granulocytes. They're your neutrophils, your eosinophils, and your basophils. If you look at your agranulocytes, which is your monocytes and your lymphocytes, you see those are clear. They don't have the granules inside your cell. Right? So the granulocytes have what's called multi-lobe nuclei. Usually has 3 lobes to the nucleus. In each one of those, you'll see the nucleus roughly has 3 parts to it, 3 lobes. Okay. If you look at the agranulocytes, they're using a 1-lobe nucleus, mononuclear. Okay. So the difference between granulocytes and agranulocytes. Granulocytes have multi-lobe nuclei and they have granules in their cell. Agranulocytes have single-lobe nuclei and they do not have granules in their cell. That's the difference. And your granulocytes are your neutrophils, eosinophils, and basophils. Your agranulocytes are your monocytes and your lymphocyte. And we'll go through each one of these here. Okay. There's 6,000 to 9,000 per microliter of blood for your leukocytes. So a total white blood cell count is performed with an instrument called a hemocytometer. Hemocytometer counts the types of white blood cells. Because when your body has infection, your white blood cell count goes up. You start making more white blood cells to fight the infection. So a low count of low white blood cells is called leukopenia. A high count or elevated count is leukocytosis. You do what's called a differential count to determine which type of leukocyte of those 5 types is in excess or deficient. So those are the tests you can run on a patient, and it tells you different things about their condition. Okay, leukocytes have a short lifespan. Remember, how long do red blood cells last in the body? Anybody remember?
120 days.
20 days.
Perfect, 120 days. Okay, they have a short lifespan. Leukocytes, white blood cells, only last a few days. So when the body is compromised, white blood cells multiply like crazy to combat the invading agent or allergen. That's why during infection, your white blood cell count goes up because you're starting to multiply. That's what's going to fight your infection. So leukocytes undergo what's called diapedesis. Diapedesis is the movement of the leukocytes out of the circulatory system towards the tissue site. Red blood cells cannot undergo diapedesis. White blood cells can. They can go out of the bloodstream, they leave the blood vessel, and they go into the tissue to where the infection is to fight the agent. Okay, so that's an important feature, a big difference between red blood cells and white blood cells. White blood cells can do diapedesis. They can leave the circulatory system, go into the tissue, and fight where the infection is. Okay, and when they're there, they release these chemicals. These chemicals draw other leukocytes to it by a gradient. You know, they follow the gradient towards this chemical. This is called chemotaxis. So there's chemicals produced there for inflammation. That's your body gets inflamed, gets red marks and all that from the inflammation. That's chemotaxis. They're producing heparin, they're producing histamine, okay, which is causing other cells to come towards it, which is chemotaxis. And it follows a chemical gradient. In other words, there's a large gradient where the chemicals being produced, and it gets smaller and smaller and smaller, and it hits the bloodstream. Once they get the area, they follow that larger gradient towards the greatest chemical release, and other white blood cells can then attack the invading agent. Okay, so diapedesis are important and chemotaxis are important. That's how your body responds to infection. So white blood cells can actually leave the blood and they produce a chemical, histamine, causes your redness, your inflammation, and the chemicals pick up that scent and they follow that scent towards the greatest part. And that's how other white blood cells get to where the invading agent is. And that's how you fight infections. Okay, so one of the first type of granulocytes, okay, our granulocytes is neutrophils. Neutrophils, granules containing chemicals to kill bacteria. It has granules inside of it. Those granules have chemicals to kill bacteria inside of them. It's typically the first white blood cell at the bacterial site. So it's usually the first one to leave the bloodstream, go into the tissue, and find the invading agent. It's a very active phagocytic cell. It tries to eat the bacteria and dissolve it. The nucleus is multi-lobed. Usually have 3 lobes of nucleus. That's your neutrophils. So your neutrophils are phagocytic cells. So usually the first one to respond to a bacterial invasion. Okay, that's your neutrophil. You take a look, you see all the granules, and all those little granules have chemicals that are going to kill bacteria. All right, next what you got granulocyte is the eosinophils. The eosinophil granules release chemicals that reduce the inflammation. They start to settle the body down and start letting it heal. So the granules in the eosinophils reduce inflammation. Okay, they attack a foreign substance that's reacted with the circulating antibodies. Okay, so your antibody comes, marks it as foreign, the eosinophils attack that. And they typically have a bilobe or two-lobe nucleus. Okay, so they attack foreign substances marked by an antibody, and they have granules, the granules inside of them reduce inflammation. And those are your eosinophils. You can see how this, you can see the size of white blood cells are larger than the red blood cells next to them too. White blood cells are almost double the size of red blood cells, double or triple. Okay, the next granulocyte is your basophil. Those are your third type of granulocyte. Okay. Granules release histamine and heparin. Histamine dilates your blood vessels. You dilate blood vessels because you want more blood to come into the infected area. Okay. You want more, that blood volume to get there, so you have more white blood cells per perfuted area to respond to that infection. And heparin prevents blood clotting, abnormal blood clotting. Okay. You don't want the blood clot to be so severe that it blocks all your blood vessels. You want to just block the area and then be contained. Okay, so histamine dilates your blood vessels, and heparin prevents abnormal blood clotting. Okay, those are your basophils. Remember, they release histamine and heparin in their granules. So the granules have different materials inside them for the different granulocytes. Okay, it usually has a whole bunch of granules inside of those. Okay, and there's your basophils. All right, the agranulocytes. First one is your monocytes. Again, monocytes are large phagocytic cells. Okay, nucleus is kidney-shaped or large oval shape, usually monolobe nucleus. Releases chemicals to attract other phagocytic cells. And it releases chemicals to attract fibroblasts. So it's attracting other cells that are going to dissolve the bacteria, and it's attracting cells that create a fibrous network. So now you're gonna start to wall off the infected site. You can take this bacteria and you're gonna form this wall around it so it can't spread. So it's doing two things. It's attracting cells to destroy the bacteria, and it's attracting cells to wall it off. Okay, if you can't kill it, you're gonna wall it off so it can't go anywhere else. Okay, the fibroblasts produce collagen fibers that surround the infected site. These collagen fibers what produces scar tissue. When you get a cut, the scar tissue is these collagen fibers, and that walls off any bacteria. That's what creates your scar tissue. It forms a wall around the pathogen to prevent it from spreading. And that gives you your scar tissue. And those are monocytes. You can see what the monocyte looks like. Monocyte is the agranular lymphocyte. And then you have the other one's the lymphocyte. Okay, lymphocyte is the fifth one. It's agranular. Okay, so there's no granules inside of it, and it forms your different types of cells. It forms your T cells, your B cells, and NK cells. Now the NK cells are new. That's when I took anatomy way back when we had covered wagons. We didn't have NK cells. Okay, well you had it, we just didn't know about them. But T cells and B cells are a part of the immune system. Now, T cells develop in the thymus, which we talked about, the thymus gland. B cells develop in the bone marrow. That's where they become what's called immunocompetent. That's where they mature. They both originate in the bone marrow. T cells and B cells are formed in the bone marrow. T cells move to the thymus to become active. Okay, but so both develop in the bone marrow. All three develop in the bone marrow. Okay, B cells stay there and become competent or mature in the bone marrow. T cells migrate from the bone marrow through the bloodstream to the thymus gland. In the thymus gland, then they become competent T cells. So you have T cells, B cells, and NK cells. NK cells are natural killer cells. These guys are unbelievable. Okay, if you have the big problem with cancer in our bodies, when you have patients with cancer is your own cells, right? It's your own cells growing at a fast rate, producing tumors, and we can't control it and we can't stop it. We don't have a silver bullet for cancer. We don't have like penicillin. Penicillin goes in the body, it finds bacteria cells, kills bacteria cells, does not kill human cells. It kills the cell wall. Human cells don't have cell walls, bacteria cells do. We have a silver bullet. There's no such thing in cancer. Cancer is our own cells gone haywire, mass producing to form tumors, cause metastasis, all kinds of problems. There's nothing we can give for a patient that's only going to kill the cancer cells. When we do chemotherapy, we're not killing cancer cells. We will eventually. You're giving patients a toxin. It's going to kill the cancer cells and the normal cells. And it's a race to see who dies first. That's what chemotherapy is. That's why you get so sick. Okay? Chemotherapy, you kill everything. You're killing the body. And hopefully you kill the cancer cells before you kill the other body cells. There is no magic bullet. Okay? NK cells have the ability to distinguish a cancer cell from a normal cell and kill it. Now, if we can figure out how it's doing it, we might have a cure for cancer. If you can figure out how that cell determines, because we don't know it, because a cancer cell, by all our definitions, is a normal cell that's multiplying at a faster rate. But these NK cells can identify it in certain cases, not all cases. I'm not saying to kill all cancers, but NK cells in our body can kill certain types of cancer that are developing by recognizing them as foreign cells and destroying them. It's amazing. They play a major role in host rejection of tumors and viral infected cells. So a lot of research being poured into NK cells. And those just came on the horizon not too long ago, within the last 15, 20 years. So they're pretty recent. So the nucleus of these lymphocytes, T cells, B cells, NK cells, is large enough and round, leaving small halo around the entire nucleus. So you look at it, it's like a little ring around the nucleus there. And the nucleus takes up most of the cell, of the lymphocytes. Again, those become T cells, B cells, and NK cells. And again, they all are produced in the bone marrow. The B cells become active in the bone marrow. The T cells become active in the thymus. Okay, so those are your agranulocytes again. Okay, the agranulocytes do not have granules. The T cells attack foreign cells directly. T cells go in, bind to it, and destroy it. B cells make antibodies to attack foreign cells. So B cells go around like a surveillance system. They look through your whole bloodstream. And if it finds something that doesn't belong there, it binds to it and sends up a flag. This little flag marks it. Once these T cells see the flag, they know it's bad and they attack it and kill it. Okay? NK cells are responsible for immunosurveillance. They always go through the system, and they can respond and attack cancerous cells that we cannot identify as foreign, but they do. So they're a very special kind of cell. All right, so that takes care of your white blood cell, red blood cells, white blood cells, erythrocytes, leukocytes. And now we got our platelets. That's a third formed element. Remember, plasma, 55% of your blood. Your formed elements are 45% of your blood. And your formed elements consist of white blood cells, red blood cells, and platelets. Platelets are derived from this thing called a megakaryocyte. Megakaryocyte is this big monstrous cell, and it gives off little portions of itself, kind of breaks it off, and these little portions are your platelets. So it's derived from what's called a megakaryocyte. Okay, fragments off, forming bits and pieces of membrane enclosed packets of chemicals. The main chemical in a platelet is thromboplastin factor. Okay, it's going to form thrombosis, and it's going to cause clotting. You have about 350,000 per microliter blood. They used to be called thrombocytes. Now we call them thromboplastin factor. Okay. And you can see in the red bone marrow, you can see the developing erythrocytes and granulocytes in the picture there. And you can see what's called a megakaryocyte. And this big thing here, one second, use my pointer again, right in the center of that white circle, that's a megakaryocyte. You can see how large it is compared to all the other cells. Okay, these are your red blood cells. The red blood cells are really small. Your white blood cells are the darker ones that are developing a little bit bigger than the red blood cells. And then 10 times, 15 times the size is your megakaryocyte. And this is what a megakaryocyte is. It's a huge cell. It breaks up these little fragments, and these fragments form your platelets. And the platelets are smaller than red blood cells, but it breaks off from this huge thing. And they go circulate the blood, and if it needs to clot, it will start clotting blood. Now, there's diseases where the platelets are too low, and people can bleed out from a minor cut. Van Willebrand's disease, there's a vitamin K factor, there's hemophilia, things like that. Or you can have too many of them. If you have too many of them, they're going to clot in the blood, and there's going to be no injury. And you're going to clot and block your blood. Atherosclerosis, where your blood will start to clot. We'll run angiograms to see if the clotting occurs in there. It can cause heart attack, cause strokes, things like that. So these platelets have to be very carefully controlled, break off of this megakaryocyte. You don't want too many, you don't want too little. You want to make sure it stays at a homeostatic condition, because either way it can be extremely dangerous. So
Are these what cause DVTs?
That can be one of the causes of, yes. Another cause can be damage or trauma to the area. And trauma to the area can cause scar tissue to occur, and these platelets can back it up and then cause a thrombosis, and that can break off into a deeper vein and block it. Okay, but a lot of it is, you got to remember these platelets accumulate, and then we're going to see in a little bit, they got other ones, and they're going to actively form with actin and myosin. Remember actin and myosin, what it did to muscles? It contracted them, right? So it takes all these platelets in this mass and starts to constrict it and form a solid mass. And that's what can form your thrombosis. That can break off and go to a deeper portion. Okay. So platelets, there are two types of diseases. There's thrombocytopenia, which is lower the number of platelets, than Willebrand's disease and hemophilia, where you can't clot your blood because the platelets are too low. And there's thrombocytosis. So if you have a patient with thrombocytosis, they have a higher number of platelets, which would make them more susceptible to deep vein thrombosis, pulmonary embolisms, stroke, coronary attacks. And because the platelets can accumulate because there's too many of them. So again, you get too many and too little is dangerous either way. So thrombocytopenia is too low. Thrombocytosis is too high for the number of platelets. How platelets function. Okay, this is what they do now. They're involved in blood clotting. They allow hemostasis. Allow the body to maintain hemostasis. They release chemicals that initiate the clotting process. They release platelet thromboplastin factor. They clump together to form platelet plug. That's the initial response to blood clotting. These plugs contain actin and myosin. And what we saw before, actin and myosin do what? They have the ratchet head, the heads rotate, myosin rotates, and you get that ratchet motion, and it constricts. So it forms a plug, and that plug becomes very dense and dense and denser, and forms a solid mass, which is good if you want to stop you stop bleeding from a major blood vessel. Okay, but if it's occurring in a normal blood vessel, that's not a good thing. Okay, so the actin and myosin are contraction, just like our skeletal muscles contract with them, and that's what forms a clot. Hemopoiesis, blood formation. There's lots of different pathways to form blood. They start with what's called pluripotential stem cells. Those can differentiate into the different types of cells that we need. Red blood cells, white blood cells, what we need. We're going to start with what's called pluripotential stem cells. They differentiate from two cells, myeloid stem cells and lymphatic stem cells. The myeloid stem cells form your blood, lymphatic stem cells form your lymph cells. We'll do the lymphatic system when the next chapter is coming up. That's another really interesting system too. So hemopoiesis, the formation of blood. The myeloid stem cells, which came from the pluripotential stem cells, differentiate to form your erythrocytes, your platelets, basophils, eosinophils, neutrophils, and monocytes. So your red blood cells, your white blood cells, and your platelets. That's your myeloid stem cells. Lymphatic stem cells form your lymphocytes or your lymphatic system. Okay, but they both came from the pluripotential stem cells, and then they form the different structures for your blood system. This is one pathway. There's going to be like 5 or 6 of these. I'm not going to test you on this. It's just, there's just different pathways your cells are going to form. But you do need to know that the pluripotential stem cells form either myeloid stem cells for blood or lymphoid stem cells for lymphoid cells, lymphocytes. Okay, and it goes through different pathways. So the pluripotential stem cells go to the myeloid stem cells. Then one pathway, they can go to a progenitor cell. They can do a proerythroblast, reticulocyte, and an erythrocyte. That's a pathway to form your red blood cells. Okay. The pluripotential cells can divide myeloid stem cell, go to progenitor cells, you can go to megakaryoblast cells and form your platelets. Okay, just a different way, a different pathway. Okay, another pathway. So they all start with the pluripotential stem cells, and they're going to go to 1 and 2, the myeloid stem cells and the lymphoid stem cells. Okay, so these myeloid stem cells go to progenitor cells, can go to myoblasts or monoblasts, go to myelocytes and promonocytes. And that's just this is a diagram that just shows you how they start. Just everything starts from pluripotential stem cells. And it goes to a myeloid stem cell or lymphatic cells, and that gives you your erythrocytes, your platelets, and your white blood cells. Okay? Your lymphatic stem cells go to your lymphocyte. Okay? That sums it up right there. This is more the details of it. Again, the myelocytes differentiate from what's called band cells. The nucleus forms a band ring around it. Band cells form what's called segmented cells. These become your basophils, your eosinophils, and your neutrophils. Your promonocytes go to form monocytes. Okay. Again, you have pluripotential stem cells. The other pathway is your lymphatic stem cells, lymphoblasts, prolymphocytes, and your lymphocytes. And again, we talk about lymphocytes. Your lymphocytes differentiate to form your B cells, your T cells, and the NK cells. Again, same picture as the diagram of everything. Just what you need to know is the pluripotential stem cells, where it starts, all of them, it breaks into 2 types: myeloid stem cells, lymphatic stem cells. The myeloid stem cells differentiate into your red blood cells, your platelets, and all your white blood cells except for your lymphocyte. Okay, it goes to everything else. It goes to your red blood cells, your platelets, and all those. Your lymphatic stem cells goes to your lymphocyte. And that accounts for your red blood, that accounts for all the formed elements in the blood, how you can form. Because remember, they only last a couple days. you have to have these pathways to generate this, and they come from the pluripotent stem cells.